So today we can start our webinar with Dr. David. He's a consultant neurosurgery interested in spine surgery in National Guard Hospital.
Academic. It's more academic lecture, and it's going to be difficult. I will ask some questions on the go, but let's see how it goes. At the end, there will be some cases just for the people to interact a little bit more. So okay. Maybe let's see how it goes. Let's see.
Sure, sure. Thank you very much. You can proceed.
Okay, can we go?
Yes.
So are we working, huh? Okay. Good evening, everybody. My name is Dr. Pinilla. Call me David, and I work in National Guard as a neurosurgeon and spine surgeon. And I want to thank all the panel to give me the chance to be here tonight and enjoy this time with me. Let's try to have a little fun and learn something. First of all, we're going to talk about degenerative spondylolisthesis. Spondylolisthesis comes from the mixture of two Greek words. That it's on one side is spondylos, meaning vertebra, and on the other side, listhesis, that means slippage or sleep. It's the slippage of one vertebra and the spine above relative to the vertebra below. The first one who used the term spondylolisthesis was Killian in 1854, but the first description was an obstetrician, a Belgian obstetrician called Ervinot, that described like a difficulty for the delivery in one of his patients. Many authors and many surgeons have given different names and have described in different ways until Newman in 1955 gave the name we know today as degenerative spondylolisthesis. In 1976, we have the first classification of spondylolisthesis, and I'm pretty sure we all know which one is type 1. That is, he described the congenital dysplastic. Which one is type 2? As the isthmic, as a defect in the pars interarticularis, type 2A, spondylolytic, type 2B, pars elongation, and type 2C as acute pars fracture. Type 3, degenerative, long-standing spondylosis. Type 4, as post-traumatic. Type 5, pathologic. Later on, Marchetti and Bartolozzi, and they tried to describe it a little bit more, and they divided it into developmental, with some variations in time, and acquired. And we will stop here and we will focus our attention on degenerative spondylolisthesis. So in 2016 guideline summary review, they gave us the best working definition as an acquired anterior displacement of one vertebra over the subjacent vertebra associated with degenerative changes without an associated disruption or defect in the vertebral ring. Let's keep that definition because it defines quite well what we're going to talk later on. We will focus on 4 different topics. First, epidemiology and natural history, some hints on anatomy, biomechanics, and pathobiomechanics, a clinical picture, and some hints for the diagnosis, and then the treatment, that is the biggest cornerstone. According to first topic, epidemiology and natural history, the prevalence in the world, it's definitely unknown, with great differences with gender and race. The general description goes from 16 to 30%, as in this study in Australian women more than 50 years old. In older white American women, about 19, 29, and older African women up to 60%. And in the Asian population, the overall prevalence is 8.7%. So there are big differences between the different races. But what is pretty clear is that it's a disease for all people, as we can see in the one on the right, the window on the right. People over 60-year-old, the prevalence goes higher and higher, up to 40%. And it's way more prevalent in male than in female. In the female than in male, I'm sorry. In female than in male, up to 6 times more prevalent in female than in male. The main level that we will have affected by degenerative spondylolisthesis is L4, L5, up to 6-7 times more than any other level. And 66% is single level. Up to 1/3 is multiple level, most of the time L5 is 1. And most of the times it's a grade 1, according to the measuring, with an average of 40% of slippage. And this is very important, because, according to the instability concept that we will talk later on. What do we know about the natural history of degenerative spondylolisthesis? That first study, Matsunaga, described what happened to a group of patients, non-surgical patients that he followed for a minimum of 10 years, 10 to 18 years. So he saw that the sleep progression, more than 5%, occurred in 34% of the patients, with a final slippage average of 15.6%, and with a slippage 25% or more in only 10 cases. And he found that in these patients happened several phenomena, like this high decrease, appearance of spurs, and sclerosis, end-plate sclerosis, and ossification of ligaments, that he described as a process of re-stabilization. In fact, what he saw is that 96% of the patients without a decrease in this height had progression of the slippage. So this is a dynamic process, this the degenerative spondylolisthesis. Another study, quite interesting, Aono and colleagues follow up 142 women without a baseline deformity of a mean of 14 years. And they describe a new developed degenerative spondylolisthesis in 12.7%, finding an increase in pelvic incidence, the inclination of L4 vertebral body, and the facet orientation as risk factors for developing this degenerative spondylolisthesis. So it's not a single procedure. It's a mixture of many different phenomena that can happen for that level to sleep, and one vertebra to sleep on top of the vertebra below. So we have degenerative disc changes that happen with age, as we saw before. Increased mechanical stress, obesity is associated with degenerative spondylolisthesis in L4-5 in women, and as an increase in load forces. Pregnancy, we know that DS has a higher prevalence in multiparous, with an increase in lordosis, probably related from laxity or the appearance of relaxing, we don't know. The laxity and the ligaments, Matsunaga in his study found that 65% had an increased joint laxity compared to 8% in the general population. Some hormonal or sex factors that we see in women, 2.5 to 3 times more, even 6 to 1, depending on the series. It's more prevalent in oophorectomy size, less prevalent in estrogen replacement therapy. And all these take the spine to sleep, and with time, some restabilization happen with these narrowing spur formation, subcartilaginous sclerosis, and ligament ossification that will inhibit the slippage. This is more or less the natural history of the degenerative spondylolisthesis. What do we know about anatomy and biomechanics? Okay, DS is a unique phenomenon in lumbar spine due to anatomy and biomechanics. It's quite unlikely to find that in cervical or thoracic spine. The segmental stability is normally maintained by a combination of the shape of vertebral bodies, discs, and facets, the elastic properties of ligaments, and the muscular support. So there are some facts that we have to know. The shear forces in the upper segment is oriented posteriorly, in the lower segment is oriented anteriorly, and the main load in kyphosis is directed into the anterior column, and in lordosis is directed into the posterior element. So we know the relationship with the degenerative spondylolisthesis and the pelvic incidence, and we find higher prevalence, or this author found a higher prevalence in when the angles of L4, L5, and S1 are higher. An increased pelvic incidence correlates with higher incidence, and increased lumbar lordosis correlates with with a higher incidence as well. It's a risk factor. And we have to keep an eye on this picture, an harmonic and a happy young patient that with time increases the lordosis and gains weight. He tries to compensate the loss of lordosis that happened with age with an increase in the pelvic tilt. And with time, he develops a degenerative spondylolisthesis. So the obesity and gaining weight with years, it's a big risk factor for this. Another risk factor that many authors highlight is the facet joint orientation. In the transverse plane, we know the chronic remodeling of sagittally oriented facet joints that happen. We know that in older adults, the angle is greater. There's an inverse relationship between the sagittal angle and the hypermobility of the lumbar spine. And Bowden found in his study that a coronal angle, the beta angle, more than 45 degrees, has a 25 times greater risk to develop degenerative spondylolisthesis. But not only in the transverse plane. Why L4, L5? From the anatomical point of view, there's a reason, and we have to know. The range of movement of flexion extension in L4, 5 compared to L5, 1 is high. So there's a requisite for degenerative spondylolisthesis. It's the relative immobility in the level below. So we know that it's more prevalent when we have a sacralized L5, even 4 times more, after we do an L5S1 fusion. And it's very interesting, the relationship with the quadratus lumborum anatomy, that it's attached to the, as we know, to the transverse process of L1 to L4, and the relationship of the iliolumbar ligaments and the L5 vertebra. That leaves L4, L5 like the weakest part in the lumbar spine. So the stress on L4, L5 is bigger. That's why L4, L5 is the most prevalent in degenerative spondylolisthesis. This is a theory, of course. And also very important, the role of the muscle support. And it's very important for the conservative treatment and the rehabilitation after that, because we know that on the muscles in the trunk and the pelvis are important for motion and stabilization. And all deep abdominal muscles, mainly the internal oblique, the transverse and multifidus, are very important for the dynamic control of the segment. So, and what happens to the disc? There are 2 theories regarding disc degeneration. Some people say that the disc degeneration leads to segmental instability and then increase of the stress on the facet joints, and that to degenerative spondylolisthesis. Even some authors, Hiro and all, describe the splitting in his study with discography. The splitting of annulus fibrosus is a very important risk factor for degenerative spondylolisthesis. But other authors have found that the decrease in the disc height increases the stability. So maybe we have a disc degeneration and initial event for destabilization, and then the decrease in the disc height and spore formation, and as a re-stabilization process, as these authors, Kirkcaldy, Wells, and Matsunaga, found in the different series. So we go again to the same picture we saw before. The degenerative disc changes, initial step, and after that, the rest of the phenomenon happen and leave us and guide us to the degenerative spondylolisthesis. So after we've seen this, what is the clinical picture that we will find in these patients? Of course, some mechanical imbalance that will lead us to low back pain. Normally, some mechanical back pain is the most common presenting symptom, normally relief with posture, with sitting down. And spinal stenosis, the most important symptom we'll see is the spinal stenosis. And spinal stenosis mainly related to central canal, area A, lateral recess, area B, and less important, but sometimes very important, in the neural foramen area C. Okay, so the neurogenic claudication, as we all know, is a, well, I should have done this as a question for all the people, but we all know it's a buttock and leg pain, discomfort caused by upright walking and relieved by sitting. Okay, and relieved by sitting. Can be unilateral or bilateral, and it's the cornerstone of degenerative spondylolisthesis, and of course spinal stenosis. So we'll see later some characteristic of the low back pain. The Cauda-Equina syndrome is not common in a regular basis in degenerative spondylolisthesis, okay? But when it happens suddenly, we have to suspect that we may have acute disc herniation or a synovial cyst. I've had several cases with hemorrhagic synovial cyst that debuted with acute Cauda-Equina syndrome, and we had to do as an A1 case, of course. So what do we know about the natural history of the symptoms? In the study in Matsunaga, he described that patients with only low back pain, or with mostly low back pain, with or without any lower extremities, most of them improved during the follow-up. And those without neurological deficits remain free after 10 years. Most of them with only minor neurological deficit or none. So what can we learn about this? That low back pain is doesn't sound like a good indication for surgery. But we know that those patients with pain in lower extremities and those with neurological symptoms, okay, deteriorated with time, or the pain remained. So we know that leg pain and neurogenic claudication, it's a more solid feature as indication for surgery. The only symptom that changed with the decrease in this height was the low back pain, okay? And up to 90% improved the low back pain with the decrease in this height. So what do we know about the natural history of spinal stenosis? I know there are different entities, but we have learned some things about this. I'm sorry. We know that mild to moderate spinal stenosis, the conservative treatment can be favorable, up to 1/3 to 1/2. And in patients with mild or moderate degenerative lumbar spinal stenosis, it's very unlikely to have a catastrophic neurological decline. Okay, those for moderate or mild. And but the evidence is not sufficient in severe degenerative lumbar stenosis. So this is something we have to keep in mind for the recommendations in the treatment afterwards. The diagnosis. Okay, this is the evidence. We're not stopping here much, but most of the recommendations are B or C or insufficient. Okay, so what do we know? We know for the diagnosis that we have to diagnose on one side the spondylolisthesis, on the other side the stenosis. What is the proof that you will ask to diagnose the spondylolisthesis, not the stenosis, the spondylolisthesis? Anyone? Okay, so standing lateral radiograms are the main proof that we may ask. Okay, so we can check the degree of slippage according to Tyler or according to Meyerding, whatever to classify. Okay, and also for all the sagittal balance parameters that we have to learn from the very beginning to apply to every lumbar spine issue. Okay, and what would be the proof of the stenosis? Of course, we all know it's the MRI. Okay, the MRI, they will show us or not the slippage, and we can find some features that will guide us into some instability, or at least we have to think about instability when we find them, like facet diffusion more than 1.5 millimeters. Okay, and in case MRI is not indicated or contraindicated, or we can have a CT or we can have a CT myelogram, just to get to know the information about the spinal stenosis. Talking about spinal stenosis, I wanted to bring up this study by CSAS. It is very important that we classify and we diagnose and we try to correlate the severity of the spinal stenosis with the image. Okay, so these offer things about morphology more than area to grade the severity of the spinal stenosis. And it is serious, according to this classification, in 7 grades, A1, 2, 3, 4. That the definition, when we see clear CSF surrounding the rootlets. Grade B, when we don't see clearly CSF, but we see the rootlets. Grade C, If we don't see any rootlet, but we still see epidural fat in grade D, when we don't see any epidural fat, okay, in his series, what he finds out is that patients with grade C and D are more prone to fail with conservative treatment. And when I thought this was interesting to be brought up. How can we diagnose instability? In the recommendations that we saw before, in the inferior part, we see there's no universally accepted standard to diagnose. The evidence is E, okay? It's I, I'm sorry, it's I. So what do we use? We use flexion extension radiography, and if the slippage increases more than 4 millimeters, or we use the MRI. We can find facet diffusion more than 1.5 millimeters, or we can find interspinous process fluid, or we can find synovial cysts. Okay, when we see these features, somehow we can infer that there's some instability in the segment. Okay, and to finish with the diagnosis, I wanted to bring up this table to differentiate. This is mostly for you residents, to differentiate between degenerative and ischemic. Okay, it can seem pretty clear, but the concept is very important that you differentiate one from the other because they are completely different. Degenerative, as we said before, is more frequent in female. It's a disease for all people, and it's more in Black population than Caucasian population. Ischemic is more in male. You can find it even in kids or teenagers, and it's more in Caucasian than in Blacks. The level in degenerative is more than 4 or 5. The level in ischemic is 5 is 1, 85% of cases. The symptoms in degenerative is spinal stenosis. The symptoms in ischemic is more mechanical low back pain and foraminal stenosis. Okay, and the image is very important for you to differentiate it. Meanwhile, in degenerative, we can find a canal narrowing, facet hypertrophy, and fluid and ligamentum flavum hypertrophy. If you look at the image in the right, you see a canal enlargement, spondylolisthesis, and foraminal stenosis in the ischemic spondylolisthesis, just to have a clear picture of the difference between one and the other. And now we go into the interesting part of the lecture and talk about treatment. Okay. Of course, we have to talk about non-operative management and the surgical treatment. The non-operative management, okay, it's extremely important. It's calculated that only 10 to 15% of cases need surgical treatment. 3 to 6 months trial of conservative is a first line in every case of low grade without neurological deficits. But there's no optimal treatment because there's no evidence. And according to the guidelines in 2014, it has to be similar to the spinal stenosis with radicular symptoms, conservative. So what will we do as conservative treatment? Okay, first of all, I'm always, and the residents have been with me in the clinic, they know it very well, that weight loss. Okay, weight loss is very important. We know from the SPORT trial that we'll talk later that obesity has a poorer outcome with conservative treatment. But when we take them to the surgical treatment, they have more complications. So very important, first, weight loss. After that, we will restrict the activity, even periods of complete bed rest. But remember, no more than 72 hours to avoid muscle atrophy. Anti-inflammatory medication. Okay, remember the weight loss. It's always very important. Remember this picture, it's very interesting. Bracing can improve. There are some studies, no evidence, but there are some studies say they may improve walking distance in neurogenic claudication. Epidural, foraminal, and facet joint injections. Epidural injections are effective, of course, but in the studies comparing epidural injections with physiotherapy, they find no difference at 6 months. Transforaminal epidural injections for relief of radiculopathy, very effective, but limited in time, 3 to 36 months. Facet joint injections for back pain relief. And physical rehabilitation. When the patient asks you, what kind of exercise I can do? Okay, so we know that flexion exercises are superior, okay, to extension. We have to use these exercises to help reduce the pain and strengthen the muscles. If it's useful for the patient, it's okay, but it will be useful if we have to take a patient for surgery for sure. What is now called pre-habilitation. Ultrasound and electrical stimulation, there's no evidence. The manipulation and chiropractor, hopefully there will be evidence as this meta-analysis will be released hopefully soon. So what do we know about literature and the difference between surgical versus non-surgical treatment? This study is very important. It was published in New England Journal of Medicine, the SPORT trial that we all know. The per treatment study found no difference between one and the other. There was a lot of crossover between the surgical and the non-surgical. But in the non-randomized as treated study, they found a great improvement in the surgical group. With the same results, studied at 3 weeks, they had the 2 years up to the 10 years update that was just released, with major improvement in up to 70%, 74% in the surgical group, and 24% in the non-surgical. But we have to know that most non-surgical patients experience some kind of improvement, okay? And we also learned that significant deterioration is unlikely to occur while conservative. Just try to keep this in mind for later. What do we know now? What is the guideline for this? In the guidelines in 2016, there are 34 clinical questions, but there's no level 1 evidence to support the recommendation. And there are 17 questions with insufficient or conflicting evidence. So what do we have? We have controversy, great controversy. So what are the options? Of course, the cornerstone for the treatment is decompression. The goal of the surgical intervention is to decompress the associated spinal stenosis. Okay, the direct decompression with laminectomy, total resection of the lamina, or laminotomy, partial resection of the lamina, is the standard. And most of the times, as we have to decompress the central area A, the lateral recess area B, and part of the foramen area C, we have to resect part of the facet joint. Always trying not to stabilize the lumbar spine, of course, but we'll see it later. The results for laminectomy in the literature goes from 69 to 84% of good or excellent results. So decompression is the cornerstone, is the goal, is the standard for the treatment of the spondylolisthesis. It was very popular in the past, and I wanted to bring this up, non-fusion indirect decompression, interspinous devices. Okay, what we know is that there's insufficient or conflicting evidence to make recommendation. And if you let me give you my experience, don't do it. Don't do it. Please don't do it. Let's try to find something that works instead of using this. Talking about decompression, we have to talk about minimal invasive surgery. Okay, there are different techniques that nowadays try to minimize the damage to the muscle and the amount of approach that we have to do. First of all, the spinous process splitting laminoplasty, in which the approach is done through the bone of the spinous process, and then we have the same approach as a midline approach, so we can do our laminectomy, and after that we close the defect. It's a laminoplasty. Okay, very useful, and when you have hypertrophic facet joints, and very useful if you want to avoid pain medication. Tubular laminectomy, unilateral approach, bilateral decompression, or unilateral approach, unilateral decompression, very useful nowadays. Very useful nowadays, and it's fast. It's bleeding is almost nothing. Definitely a step forward. And present and also future endoscopic bilateral laminectomy. Okay, nowadays you can find tons and tons of studies talking about this. What we know is that MIS has comparable clinical outcomes compared to open surgery. Reduced cost, shorter operation time, decreased blood loss, shorter length of stay in hospital. The results, the outcome is the same, they're comparable. And the grade of recommendation for this kind of approach is B, but it's getting better. So my recommendation, personal recommendation, C or D or E, would be learn these approaches. They will be very useful for you and for your patient. And we have the fusion surgery. we can do direct decompression plus fusion. Direct decompression plus fusion. We can do posterolateral fusion, laminectomy plus posterolateral fusion. Not done anymore. Not done anymore in a regular basis. Most of us do laminectomy plus instrumented fusion, or laminectomy plus instrumented fusion, pedicle screws plus interbody fusion. That can be a PLF, it can be a TLF. What do we know? The addiction of an interbody graft shows superior radiographic fusion, improved disability, and reduced back pain. But that clinical improvement in the literature is very small. So we have to make a balance with longer operative times and more complications in these approaches. And we can do indirect decompression plus fusion with approaches like ALF or anterior to psoas or lateral transpsoas approach. Okay, all these techniques are associated with increased fusion rate, radiological and clinical improvement, and greater increase in lordosis and foraminal height and posterior, but also more complications. We have to wait perfectly if our patient really needs it or he does not. The recommendation level is B or C or I. Okay. So the facts. In the recommendations, in the guidelines, we find that surgical decompression alone improves surgical outcomes compared to medical conservative treatment. There's a recommendation, a C, saying that yes, it's better. And the addition of lumbar fusion to the decompression, they say that in single level, addition of fusion is better than the outcome to medical interventional treatment, but only for single level, not for multi-level. So we know with the sport trial that surgery has a better outcome than conservative, and even better in young population, less than 67, and leg symptoms, more than only low back pain. So, and the addition of instrumentation nowadays, we know that it improves fusion rates, but it's not suggested to improve clinical outcomes. So what do we know? That instrumentation is better than decompression only in imaging. It's controversial. Many studies show that fusion significantly improves over decompression alone, and the better the fusion, the better the outcome. But it's controversial. Adding interbody fusion, there's insufficient evidence. No difference in the fusion surgical technique. And there's insufficient evidence for anything else. So what can we do? And that's the question that we do in clinic every day. So these other meta-analysis that what shows is that the decompression and fusion there's no difference in the outcomes, but decompression tended to be in older patients with leg symptoms and with less complication, but more reoperation, and fusion tended to be in younger and back pain patients with higher complication rate, but less reoperation at a higher cost. There's a weak evidence for comparison, but the conclusion in this meta-analysis is what we all know, that we need future studies for patient selection. We know some patients will do fine only with decompression, many of them, but some patients will need fusion, okay? So that's something that we have to think about for the future. So, according to the past medical history, the age, comorbidities, functional status, and expectancy of the patient, and the symptoms, claudication, leg pain, more than back pain with leg pain, or only back pain, and the radiology, instability. No, we can choose no surgery, advanced stage, or comorbidities, or the patient expectations are not very high, and which conservative treatment is effective, or only low back pain that we can treat conservatively. Okay, no surgery is an option. Only decompression in all the patients, let's say all the patients, without significant low back pain. With some comorbidities, we don't want bigger surgeries on these patients. Without instability or patients with this disease. Patients with not higher expectations regarding low back pain. And always I put the accent on MISS. Please keep that in mind always. With patients, we will think about decompression plus limited fusion, younger patients with some low back pain in the lower limbs, as well, where we find some instability, okay, and the height of the disc is preserved. And when in patients, we don't see imbalance. Why do we say this imbalance? Because extended fusion, we have to use in patients with more imbalance. And this is not that clear. So in 2014, these authors in France, Olivier Gil, created this new classification, 2016. They described the degenerative spondylolisthesis in a classification in 3 times, in 5 types. Type 1 with an harmonious spine, with a lordosis, preserved lordosis. Type 2, compensated malalignment with a hypolordotic, but still properly aligned. And type 3, if there's a global misalignment. Type 1, if a lumbar lordosis is preserved. Type 2, if lumbar lordosis is not preserved, but there's no misalignment. Type 3, if there's misalignment, the SVA more than 40 millimeters. What is important? Why is this important? Because in type 1A, this preserved segmental lordosis and global lordosis, and there's no misalignment. They say, okay, do a segmental approach, just treat the segment. You can do decompression plus minus fusion, depending on other factors. But if we find more of the features of of misalignment and imbalance in our lumbar spine, we have to do more aggressive treatment to avoid future complications. This study, remember it, is very important, and we will be talking about this in the future. And to end it up, if the patient needs interbody fusion, remember this other approach that we talked before. If the patient needs height restoration and lordosis, maybe you should have to think about these other approaches like ALEF, XLEF, and OLEF, depending on what you need. Okay. So we've talked a lot. Let's see some cases, and I will need people joining us and answer for questions. May I have some people talking to me?
Yes,
Ahmed, are you here?
well, yeah. We have a couple of questions if you want us to answer.
Oh, yeah, this is the moment.
Or you want it after the cases?
No, it's okay. No, it's okay.
So we have a question about the...
How can I see the questions?
Yeah, you can click in question and answer.
Oh yeah, it's here.
Yeah. So the first question about the facet orientation, can you explain more? And how can it interfere with surgical management?
Okay, I would like to go a little bit backwards. It's a lot backwards. Let me find out. Well, okay. The definition of degenerative spondylolisthesis is the slippage of the vertebra above with an intact posterior arch, posterior structures. So for that to happen, the facet joints have to remodel themselves, because in the natural position, they are oblique. So the superior facet of the vertebra below, it's stopping the vertebra above to slip, to go forward, to slip forward, okay? So you need that sagittal orientation of the facet joints for the vertebra above to slip without any stoppage of the vertebra below. And we know that with age and with increasing lumbar lordosis and the degenerative spondylolisthesis, the sagittal alignment of the facet joints, it's higher. So that's why this author said that when the angle compared to the coronal angle, to the coronal axis, okay, if that angle is more than 45 degrees, there's 25% more risk of having degenerative spondylolisthesis. Some people say it's a risk factor, some people say it's a consequence of the degenerative process. But we know that when the facet joints are more sagittal, that patient is more prone to have degenerative spondylolisthesis. Is it a little bit clearer?
Thank you, Dr. Dave. We have one question, but I think we answered it in the previous slides about indication for surgical management and degenerative spondylolisthesis. Last question we have here about cases of stenosis and instability.
Yeah.
Is decompression enough, and will this increase the instability?
I mean, what do you think? What we said before, it was all about that. If there's instability and you think that patient, that segment is not stable enough, what do you think will happen if you just decompress? I mean,
the instability will increase. The decompression.
That's the question. In some patients, all patients with just neurogenic claudication, and you don't want to do a big surgery, but that patient will not have a big instability. So that's the clear case that you will choose for sure, just decompression. But you find clear instability in the segment, and you do a decompression, you're weakening the structures in the posterior elements. And if my patient has stenosis and instability, definitely my first choice would be fusion. Definitely. You can do minimal invasive surgery, trying to preserve most of the structures if you're afraid of doing fusion, definitely. But your first thought has to be fusion if there's instability, by definition.
So we have two questions more. You want us to go to the cases, then back to the question, or to finish it one time and go to the cases?
No, let's finish this too. The pelvic parameters. Okay, yeah. But I try. It is kind of important. I mean, we know when you're doing fusion that if you don't preserve lordosis and you don't preserve the balance, trying to keep the pelvic tilt below 20-25, trying to keep the lumbar lordosis, PI minus LL in the range of 10. We know that the adjacent segment degeneration is higher. And we know that the long-term outcome is worse if you don't keep it. So we should try to keep lordosis. We should try to keep the pelvic tilt and the compensation in the physiological range. I mean, it's something you can always attach to for your patient outcome. I mean, from the you need to check if the patient is doing fusion. You need to check if your patient is well aligned. You cannot control pain, but you can control radiology. So for you to be able to tell your patient, and surgery went well, and I don't know why you still have back pain. You're well aligned, and you're not unbalanced, and there's fusion. I mean, at least you have some objective measurements to tell your patients.
Okay. So
a lot of questions, huh?
Yeah. You want us to go to the cases? We are okay. And
let's try to do some cases. They're not simple cases. They're just some examples. Just some examples. Okay, here we go. Anyone? I mean, they're simple. They're simple. And only it's simple answers. I mean, I'm not telling you to tell, I'm not requesting anybody to describe. Okay.
We have Balqis, one of our
okay. Akla was Akla. So we have a female 62-year-old without relevant comorbidities, a very active nurse, non-obese.
Okay.
With a severe low back pain, chronic but severe for years, radiated to both lower limbs without neurogenic claudication. It's mainly radiated radiculopathy.
Okay.
With the treatment that's been conservative for years, with a great disability. It comes to your clinic and tells you, doctor, what can you do for me? What is the first thing you asked her for?
One of the questions I'll ask is what kind of conservative therapy she tried?
Okay, I've done physiotherapy. She does Pilates twice a week or 3 times a week. She's gone for injections 3 times a year for the last 5 years. So she's reluctant to have a surgery, but she doesn't see any other option. So she comes to your clinic.
Any radiculopathic symptoms?
Oh, she's got a bad L5 and L4 radiculopathic numbness. Yeah.
Right.
No weakness. No
So,
weakness.
yeah. So this, if the image indicates, so this is an indication for surgery. The patient failed.
Surgery of what?
No. First, I'll see the images. I'll order her.
Okay. What kind of image would you ask for?
We'll ask for plain X-ray first. Lateral plain X-ray.
Plain X-ray. Okay.
Yes.
I'll give you the whole picture. Oh, whatever. Okay. This the X-rays. Okay, it's a complicated one.
Yeah, I can't really. All right, so she's a scoliotic patient.
Mm-hmm.
I'm trying to look at her, just trying to look at the lateral lumbar spine X-ray, but I can't really zoom or see clearly the lower spine levels.
Well, I can see it, but I don't know why you don't. But it's a L4-5 degenerative spondylolisthesis with generalized this disease, and then you have the coronal scoli.
Yeah, so she's a scoliotic patient with L4-5 spondylolisthesis. So we'll go for the next step, and we'll order for an MRI to evaluate for. Yes.
Okay, here we go.
All right. So there's all right. So sagittal T2 MRI of the spine that is showing L4-5 spondylolisthesis, grade 2, grade 1. Sorry, and it's causing spinal stenosis.
Mm-hmm.
Do we have axial cuts as well, or? Okay, I can see in the lower picture.
No, I don't. This is all we have. Okay. But this is
the lower picture on the.
I should have. Yeah. This is just an example. I mean, I'm not asking you to tell me exactly what would you do in a case like this, surgically speaking. It's for you to know, and for you guys to see that sometimes you have a complicated case, and you have to have what do you need to have clearly in mind in that case like this?
Number one is her clinical picture, whether there is radiculopathy or not, and the style of conservative therapy. So this is the first thing. The second thing is the stability and the MRI measurements. So the grade of this the spondylolisthesis, number one, and number two, we'd like to look at the facets, the shape of the facet, and also the degree of the facet. Yeah.
Okay. I mean, the clue in this case is not. I mean, it's pretty clear that the patient has got one of the worst spondylolysis that you may find. That for you to keep in mind that surgery in this patient is going to be complicated. It's going to be a big case. You cannot do segmental surgery in a case like this with this deformity. So that's what I was saying in the classification before. She keeps lordosis, but there's a big deformity. So when you have degenerative spondylolisthesis and deformity, you have to think differently. You have to think about complicated surgery, different approaches, or a posterior big surgery. This is not the scoliosis. Adult scoliosis is different than the kids. The kids behave one way, but this is all stiff. So if you want to modify this scoliosis, you have to do a big surgery. Okay. Just wanted to bring you a difficult case. Not important in a talk like this at this level. This second case, we need to do it. So we have this female, 83-year-old, obese, heart disease and diabetic, not active. She's been chair-bound most of the time with a severe low back pain, and not documented neurogenic claudication. And the conservative is effective. What would you do? Look at the facets and look at the canal stenosis.
Nada, go ahead.
Hello. I think Hello. I
What
think
do you see in the image? Try to describe a little bit the MRI.
there is nerve root decompression.
So what do you see in the MRI? What is that MRI? What do you see in the MRI? You have 3 cuts, paramedial and medial, and 2 cuts in the axial. It's pretty focused on the problem. So read a little bit the MRI. There are several things you can see.
Syndrome. Cauda-Equina syndrome.
Cauda-Equina syndrome. Okay. Okay. So what do you see in the MRI? Try to describe. What is that? What is that MRI? The cat's about. It's a sagittal T2.
Contusion.
Sagittal T2 MRI, huh?
Yes, one of the lumbar vertebrae is compressed.
You take a look at the alignment. You take a look at the alignment, and you see L4-5 spondylolisthesis, grade 1, according to the MRI. Okay. And in the vertebral bodies, you can see there's a fracture in one of the vertebral bodies, huh? And how are the discs?
Yes.
How would you describe the discs? There's some degenerative
protrusion.
disease.
There is protrusion, but it's not. There is no hernia, but there is protrusion.
Okay, and you can see spondylosis, generalized spondylosis, more intense in L4-5 level. And you can see hypertrophy and hypertrophic and some fluid effusion in the facet joints. Okay, so that's what you read in the MRI. So what would you do in this old lady?
Segmental approach.
Segmental approach. Okay. Okay. Why?
One of the vertebrae is broken.
So another opinion?
So we have Turkey. We can make it a multi-people discussion. Turkey.
Okay. Okay, Turkey. Turkey?
Hello, can you hear me?
Yeah, clear.
Yes, good.
What would you do in this lady?
We can see the patient is having multi-level degenerative disease with multi-level stenosis, plus there is L4, L5 and L5S1 spondylolisthesis, grade 1 associated with the pseudodisc that the patient is having with multiple foraminal stenosis. The patient is 83. I want to know what's the, I'm sure that she is having urinary symptoms and associated with her cloud. She doesn't have.
She has occasional radiating pain to the right leg in the L5 territory, but she sits down and she's happy.
Okay.
With the pain in the leg. I mean, she's not happy with the low back, but she's happy with the pain in the leg.
I forgot to mention the image is that the patient is having chronic fracture of, I think it's L3, with a multi-level facet arthropathy.
So the quality of the bone is not expected to be ideal, huh?
It's not, no. I would avoid the minimal invasive surgeries in such patient after trial of all the conservative measures that with her. Mm-hmm. Secondly, the patient is a candidate of PLEF with interbody fusion between 4 or 5, and that will increase her brain with the decompression, of course.
Okay, according to what we've been talking, definitely that would be the approach. But what we did was injections and medication, and we didn't touch because of the quality of bone. The moment you put a screw in a patient like this, you're in trouble.
She has
and the patient is in trouble too.
She's 83.
So this patient, it was clear for you guys to say, please don't touch her. If she's my grandmother, please don't touch her. That's what I meant. But the approach you had was good. Was good enough. Okay, was good enough. But the patient did well, and she's very happy. Okay. Let's try another one.
I did
So
that.
we have this male, 51-year-old, hypertense, diabetic, and obese. And he is an active worker with a chronic low back pain, but moderate, not much. With a severe neurogenic claudication, less than 100 meters, with episodes of right L5 radiculopathy, not many, but some. And the conservative treatment with some physiotherapy and a couple injections is partially effective for the last 6 months. But he is not happy. He can't walk. He cannot. He's sitting, even when he is watering the garden, he's taking a stool with him so he can sit down every once in a while. So he's not happy with his neurogenic claudication. What would you, this is the MRI. We have it clear that it's okay, this is the MRI.
So can we have anyone to read the MRI and to discuss the case? So we have many people. So I will choose
many people.
I will choose one randomly. Muhammad Baqi.
Okay. Hi, Mohammed.
Yes, hello, Dr. David. Thank you for the.
So, what do you see here?
In the sagittal images, I see T2 images with spondylolisthesis at the level of L4, L5, causing spinal canal stenosis at the same level, and another disc at the L5, S1 level, moderate size. Also, there is significant posterior element in the form of ligamentum flavum thickening, also demonstrated in the axial images. Axial images again redemonstrating the severe stenosis and congestion of the spinal roots. Yeah, are these the same levels?
So,
axial images or
this is L45. The axial is L45.
Okay, so there is severe.
I don't have any image
stenosis.
I don't have any image of L5 as one.
Okay. Any images? Any X-ray images? Dynamic images?
No, I don't have them. This is a case from Spain, and I don't have them. I'm sorry. I'm sorry.
Okay.
But this is what we have. This patient came to your clinic. There's no X-ray. It's not available. Machine is broken, and you have to decide. What would you do?
I mean,
what would you suggest?
Conservative. He already tried conservative. I think if this patient comes to me with this images and the symptomatology he's having, I would consider even surgery from the beginning. Now, especially he's having already tried the conservative one.
I agree with you.
Surgical.
I agree with you. What kind of technique would you do here?
He's young, as you said also active workers. He's relatively young, 51 years old. I think decompression with fixation would be optimal for him.
Excellent. What kind of fixation would you try?
Interbody fusion, TLF.
Good enough. That's what we did. A TLF, a segmental.
Yes.
And you know what happened? This was years ago. You know what happened? That L5 is one disc.
Yeah, that's what I was trying to mention. Did he address the level below?
2 years later, the patient deteriorated again.
Okay.
And we did an ALF because we needed some lordosis because the level degenerated too much. So just remember this. When you have another deteriorated disc with a loss of lordosis, if you look at the level, if you look at that L45, L51, normally, what is the relationship with lumbar lordosis and L5, L4 to S1 lordosis? What would be the rationale to keep in mind? Dr. Mohammed.
I'm not sure I'm getting the point right. Again, can you repeat the question?
Okay, so what, I'll make a more direct question. What is the percentage of lordosis that has to belong to L4-S1 from the total of the lumbar lordosis to be harmonic?
I'm not sure.
Okay, so lumbar lordosis normally is around 60 degrees, 55, 60 degrees, okay? So 2/3 of the lumbar lordosis must be in L4 to S1. If you don't achieve that, you will be putting too much load on L3-4. And in this case, as we didn't correct, L5-S1 is deteriorated. This is not adjacent segment degeneration. The segment was already degenerated. So the patient just failed because we didn't foresee that that level was going to fail. Definitely it failed. And now the patient is happy. Now the patient is very happy after the second operation. After the first one, for 1 year, he was okay. Second year, he was miserable. So just remember that. And remember to look at the lordosis, to look at the pelvic incidence. Try to remember all those parameters. Okay?
We have an answer. This case is ALIF is fusion and deformity correction is good for this case, or?
If I mean, this is an eternal discussion. What kind of approach would we choose in our patients? But if we really feel that we need lordosis, we have to at least keep in mind to have ALIF for L5-S1 and OLIF, XLIF for L4-5 and L3-4 and L2-1 and L2-3 and L2-1. Because with TLIF and PLIF, the amount of lordosis that we can give is very limited. No more than 2-3 degrees. It's very limited. We can try a very anterior cage with some osteotomy, and we can try some lordotic reduction. Yeah, but more than 5 degrees is very uncommon. If you need 15, 20 degrees, you need to go anterior and break the ALL and do it. Definitely. So we have this female, 61-year-old. She's hypertense, diabetic, and mildly obese. Not active life as a housewife, but normal life, normal activity for a 61-year-old woman with a moderate chronic low back pain that appears in several visits to ER with excruciating left L5 radiculopathy. And the conservative for 1 month, that is the acute episode, 1 month, she hasn't improved a little. She's bedbound, crying in pain because of the left L5 radiculopathy. So there's no X-ray, sorry. You have to believe me. And she brings an X-ray with a grade 1, no more than 10% L4, L5 degenerative spondylolisthesis, L3-4 spondylolisthesis, and some loss of lordosis, but the patient, it's not the standing X-rays because it's excruciating pain, and she brings this MRI. So what do you see here?
Okay, this is
there's a spondylolisthesis. I can promise it's not only spinal stenosis.
You mean this is a fracture bars spondylolysis, or it's?
It's degenerative spondylolisthesis.
Degenerative.
There's no X-rays, but you have to believe.
Okay.
So
this patient.
This is the MRI when the patient.
Yes, this is the patient.
Okay. Yep.
It's obvious that she has L3-4 marked stenosis. As you said, she tried conservative treatment, which was not effective, and she is in severe pain. Actually, she needs decompression. This is the main target. It may relieve her pain. And as you mentioned that with X-ray there is instability, she will need fusion also.
She will need fusion also.
Yes, decompression and fusion. Yes. She will need TLIF.
Okay.
Yes.
Okay, it's an option, definitely, as we've seen in our talk. We
Yes.
can always fuse, but in a case like this,
Yes.
we did just the decompression. We use a tubular decompression, just from the right side. Then we have bilateral decompression, and I chose the right side because if you look at the actual image, the facet joint in the left side is very deformed. It's really deformed, and there's a real compression of the lateral recess. And I wanted to approach from the other side, from the contralateral side, so I can have a good view of the facet joint and the nerve root. And if you look at on the left, you see the CT scan, post-op CT scan. The decompression was excellent. The patient improved. Her back pain remains being her back pain, but she's happy with that. She was not happy with the L5 radiculopathy. It's been 1 year, and she's very happy.
Yes.
So the compression helps, and it can be the treatment for the patient. Definitely, it can be the treatment for the patient.
Yes. Thank you.
Thank you very much, Akon.
Thank you.
So as conclusion for today, first of all, degenerative spondylolisthesis is frequent, mainly all people, mainly female, okay? The natural history progresses a little bit, and only some of them, and the low back pain tends to improve. Keep in mind that young people will have low back pain, may be a problem, but for all people, low back pain normally is not a big problem. From the clinical point of view, more frequent is low back pain, but it's more important than neurogenic claudication and the leg symptoms. This is the take-home message. It's unlikely to have a catastrophic neurological decline in mild and moderate cases. So you have time. Treat your patient. Try conservative. Don't rush. In the diagnose, please X-rays. X-rays. And normally most of the residents always go straight for the MRI. Look at the X-rays, and the X-rays are very useful. And in degenerative spondy, they're very useful. They're very useful. There are many things to look at and to calculate, and always in the MRI, look for indirect signs and possible instability. In the treatment, always conservative first, unless said otherwise. Okay, there are some cases that you will go straight for surgery, and you have some acute cauda-equina, or you have an acute. Okay, but that's not common. The normal patient is the patient who comes to your clinic with neurogenic claudication, low back pain, with radicular pain. So please always go for conservative and insist on weight loss and the medication and the exercise. People are lazy, and all people are lazier. Just remember that. Surgery when it persists, okay? And when surgery, first individualized. See your patient and talk to your patient and talk about the expectation that your patient will have and the family, and how big surgery can the patient take. It's very important. Not for this, but there were some series for adult deformity that they were talking about mortalities up to 35, 40% of the cases. Come on, maybe just a simple decompression is enough, or segmental, or something minimal invasive. Just talk to your patient, get the expectation, just talk to them. And always just get on the sagittal balance wave. It will avoid some future complication. I showed you one of my complications, and I can show you a lot more, but it would be about. So just keep that in mind, okay? And for the future, remember MISS is the present, is the future, and would be the next future. Everything tends to be minimal invasive. And why not? Let's try to get into trials to be able to classify the patient, select the perfect treatment in each case. For the quarantine, okay, always remember to keep your routine at home. And thanks for your kind attention. Thank you very much.
Thank you, Dr. David.
Thank you, Dr. David, for the good presentation. I have one question.
Okay.
What do you think about the endoscopic?
Oh,
yeah. Is it a good?
No, I'm a big fan. I've been in different courses and done in cadaver. I'm trying to convince Dr. Al-Khani that I think he is listening to me to get into that 150%. I think it's the present, it's the future, and once you see the guys who have the experience and the expertise in it, you don't want to do anything else. But it's difficult, and the learning curve is it's long. You need an average of 30 cases to master it, or at least to tell that now I can run. And it's complicated. It's complicated. But once you start doing that, I mean, I'm pretty sure you don't want to do anything else. There's some intermediate step. I mean, the tubular retractors are very useful for the lumbar spine decompression. Very useful. And the over-the-top approach for bilateral decompression from unilateral approach, I think it's the first step for you to get used to the anatomy in a small field. But if you ask me about endoscopy, come on the phone.
Okay, thank you very much, Dr. David. I appreciate your participation to our webinar, and thank you for Neuroscience for helping us with this
definitely. Thank you very much, guys. It's been a pleasure. I hope you learned something, and hopefully that we can meet again.
We are looking forward for more lecture, Dr. David. Thank you very much, everyone.